Sir. Sir, it's 3, 2, 1. We are live now, sir.
Good evening, viewers. It is a wonderful evening, and I hope each one is enjoying less of winter. The temperature is just wonderful and very conducive to learn from each other. I am Rajiv Agarwal. I am a practicing cardiologist in Meerut. I practice whole range of cardiology, from preventive medicine to clinical medicine to some kind of intervention, pacing, and all those things. We are going to talk about beta blockers in reduced ejection fraction. It stood the test of, and 1962 we had first beta blocker as propranolol. James Black in ICI company. I don't know many of you whether know the ICI company, but I distinctly remember they discovered, created something like propranolol, and we had a trial, famous trial, beta blocker heart attack trial called BHART trial. And surprisingly, the dosage of beta blocker propranolol use was 40 milligram twice a day in a very conventional, orthodox, uninterventional environment. And beta blocker emerged as the medicine because it reduces infarct size, it reduces mortality, it preserves EF. Today, you will realize that that dose is so atrocious, propranolol being given twice a day. But that was a different era. There was no lysis, nothing, and heparin, all those things were there. So beta blockers has stood the test of time. I forgot, James Black got the Nobel Prize for his discovery in 1988, roughly about 26 years later. Beta blocker has stood the test of time. We used to read about a trial called Maffei trial, which if you treat hypertension with beta blocker, it reduces cardiovascular mortality. Beta blockers have stood a test of time in post-infarction patient population and is a golden molecule in patients with reduced ejection fraction. Today, I have two very distinguished speakers, Dr. Sameer Srivastava, who is in chair of echocardiography in Ascot Heart Institute, and a wonderful, let me say, one of my is to learn from him. He's a voracious reader, and on top of it, he's a person who analyzes things. I'm sure we will have a good experience blocker in. The another speaker is Dr. Nagendra Bhupati. He is again a very good clinical and intervention cardiologist who has a training in coronaries and structural heart, based in Chennai. I had the pleasure of working with him in Meerut for some time. I even today lure him to come back to Meerut. Problem between us. He is willing to come over to Meerut minus his wife. So I do not know whether I can get him married again in Meerut and all that, but Gayatri is like my daughter, so that is a problem. So I miss him every day in my life, on academic front, on professional front. Again, a wonderful speaker. So I have taken too much of time. I invite Dr. Sameer Srivastava. And once again, I assure you that it will be learning for all of us. Sameer, I invite you and welcome you, and the platform is for you now. Thank you. Sameer, you are not live. You are muted. You are muted. Yes.
Can you see my slides, sir?
Yes, you are perfect now. You can start.
Thank you very much for, sir, very kind words. And I wish my wife was around to listen to such good words. And one more feather in your cap because she thinks very highly of you in any case. Anyway, thank you. And this evening we are going to talk about beta blockers, and my defense in favor of beta blocker will start with its title, The Big Brother in Treating Heart Failure. Now, beta blockers in current cardiovascular practice are something of this sort, because if you look at the distribution of beta blockers, the beta blockers by and large in the heart are beta 1 blockers, and in the lungs are beta 2 blockers, though there is a significant overlaps at times. But if you want to be very, very conservative, and the purists will say that no, beta 1 and beta 2 both exist in the heart, and so do they exist in lungs. But majority betas are in the heart are beta 1 and beta 2 are there in the lungs. Now, when you look at the effect of beta blockers, all of us know that beta blockers competitively inhibit the myocardial effects of circulating catecholamines. So the neurohormonal bad parts which are so prominent in heart failure are negated by beta blockers, and they reduce the myocardial oxygen consumption by three things. One is they lower heart rate, they reduce afterload by reducing blood pressure, and they reduce myocardial contractility. Now, the effect of these beta blockers by and large could be because of effect on the heart, effect on the arteries, and so to say in the kidneys as well. So betas are present all over. Now, if you look at the nutshell effects of beta blockers are that it slows down the SA node, thereby reducing the sinus rate. It increases AV node refractoriness, slows down the ventricular response to atrial fibrillation and atrial cardia. So it has some relevance in atrial fibrillation, though the literature is very, very divergent as far as results is concerned, but we'll talk something about it in a little while. It dilates the arteries, lowers the blood pressure, reduces contractility by, and of course, cardiac output somewhat also reduces, but it compensates well because the arteries, when they dilate, especially the newer ones, like if you look at the carvedilol, so it is a non-selective beta blocker with alpha-1 blockers, so it has got dilatory properties as well. So you know that it reduces myocardial contractility, but it does not reduce the cardiac output because the afterload also reduces some bit. So your cardiac output net is maintained to a large extent. Now, also it suppresses the formation of ventricular arrhythmias, which also is very, very majorly contributed. And the most dramatic effect is when you have to talk about the after depolarizations and things of that sort, that you will realize that beta blockers have a very great strength in control of ventricular arrhythmias. Now, regardless of how much we know about beta blockers, we know one thing for sure, that they are underused in post-myocardial infarction and coronary artery disease. And not only that, we are so fearful of using beta blockers in COPD, in heart failure, in diabetes, because we assume that they invariably and always worsen the diabetic profile, and peripheral vascular disease. We'll talk about these things in a while. Now, this is what Braunwald had said, that if you look at the cardiovascular continuum, which starts with risk factors, goes on to atherosclerosis, left ventricular hypertrophy, coronary artery disease, myocardial ischemia, subsequently going on for coronary thrombosis, eventually myocardial infarction. And this neurohormonal activation thereby acts and arrhythmias and eventually remodeling ventricular enlargement, CHF, and ultimately death. When you look at beta blockers right from risk factors, which includes hypertension. Now, hypertension, the purist again will say that beta blockers are not the things to be used in hypertension. But we can get into this debate at some point that whether the trials have been fair or unfair to beta blockers as far as hypertension is concerned. But rest of the things, we are very well convinced that beta blocker has a space which is unquestionable in atherosclerosis, ischemia, myocardial infarction, arrhythmias, and ventricular enlargement, CHF, and thereby preventing death. Now, these are beta blockers in heart failure and beyond. It reduces heart rate. It blocks the renal renin secretion, reduces extracellular volume in ventricular volumes. It has a direct antiarrhythmic action. It has direct vasodilatory or impedance reduction. It has direct reduction of myocyte hypertrophy. And we know that left ventricular hypertrophy is an independent risk factor for sudden cardiac death. It is anti-apoptotic and other molecules and cellular effects which are known and unknown, and the world is still trying to discover that. Where are the rumors? The rumors are that beta blockers are dead. Well, the elder brother who's always present to help the young lads in treating hypertension and heart failure is when to start and when to stop beta blockers is the question. But beta blockers exist and they are not dead. Which beta blockers? When it comes to heart failure, there is enough and more data that carvedilol, metoprolol, not tartrate, but metoprolol succinate, the longer acting one, and bisoprolol have the very, very large trial respectively, and they can improve overall and event-free survival in NYHA from class 2 to 3 heart failure. 4 is a little dubious, where in fact in class 4, if the patient is already on beta blockers, you can reduce them, but should not stop. But in class 4, probably it is not wise to start it at that point of time. Other beta blockers like atenolol or propranols are not tested and should not be used. Actually, most of the hypertension trials which had atenolol was the ones which actually put beta blockers in the back burner. And 2 trials that I can often remember is Escort blood pressure lowering arm. Again, they used atenolol, and LIFE study where they use atenolol again. These were the 2 trials which were negative trial, and this actually were pushed back. And understanding that atenolol is basically a hydrophilic kind of a beta blocker. We're not going into the discussion for that, but for the timing, atenolol and propranolol should not be used in treatment of heart failure. Where does nebivolol stand? We'll come in a while. Now, the discussion forum in European Society of Cardiology in 2018 discussed this very, very elaborately. And concerning the degradation of beta blocker use in 2018 ESC ESH hypertension guidelines, they said that beta blockers may be more effective in patients with hypertension. Again, you know, it's not the first line. We know that the current recommendations do not recommend that beta blockers should be the first line of therapy for hypertension. But this is what the discussion happened in 2018, which was published in the European Society of Cardiology. And they said beta blockers may be more effective in patients with hypertension who are younger than 60 years, resting heart rate greater than 80 beats per minute, and is often regarded as a practical surrogate of adrenergic activation and increased cardiovascular risk. So whenever you are expecting adrenergic activity, sympathetic overdrive, then beta blockers can and should be used. Number 2, they said that beta blockers are part of the World Health Core list of medicines requiring for implementation essential cardiovascular disease interventions in primary care. And lastly, one more point which they discussed was that beta blockers should also be considered in step 1 or 2 of core drug therapy for uncomplicated hypertension, especially in young patients without a diuretic. Now here we are getting the beta blockers and pulling them back into the space. When it comes to CHF, we know that they have got proven effective therapies on all-cause mortality. If you look at this, beta blockers have a very wide base. Then further narrower are ACE inhibitors, ARB and R-mini now, aldosterone blockers, ICD, CRTD. And somewhere in this space, Now the SGLT2 inhibitors are encroaching very rapidly, which is basically an anti-diabetic drug, but has got enough and more data now that they can be used for non-diabetic heart failure patients as well. Now, these are the pharmacological approaches to reducing mortality in heart failure with reduced ejection fraction. We know that heart failure can be divided into preserved ejection fraction, reduced ejection fraction, and there is something known as a mid-range ejection fraction, which is somewhere around from 40 to 49%. But if you talk about heart failure with reduced ejection fraction, the bedrock, the four pillars of therapy are ACE inhibitors or ARBs and ARNI. Of course, I'll combine all these three in the same bucket. Beta blockers, MRAs, and neprilysin inhibitors, along with valsartan. So this is the fourth. And of course, SGLT2 inhibitors, which are, again, like I said, pushing themselves hard into finding a space for themselves in heart failure therapy. These are the beta blockers guideline, class 1A for any ejection fraction lesser than 40%. So ST elevation myocardial infarction with ejection fraction less than 40%. With heart failure, class 1A indication, whether it is the American Heart Association or whether it is American College of Cardiology, either which ways 1A indication is a very well-established, unquestionable indication. Now, for non-ST elevation, again, it is 1A. So for ejection fraction lesser than 40%, we know that beta blockers have to be given. Now, when it comes to ejection fraction greater than 40%, for ST elevation MI, the American Heart has a 2A indication, and American College of Cardiology is a little more liberal, and it has gone on to class 1B. And they said that for next 3 years, keep them on beta blockers, and thereafter, if you have to continue, then it becomes a class 2A indication. And class 2A indication is not a bad indication. It's a very strong indication. Unlike class 2B, where you can give, you may not give, which is very close to class 3, which means that do not give, it may be harmful. Now, when it comes to non-ST elevation MI with greater than ejection fraction 40%, then American Heart Association is by and large quiet on it, but American College of Cardiology is 2A indication. These are the 4 beta blockers that have been shown to reduce mortality in heart failure. And these are the large trials. SIGBIS is the trial which used bisoprolol. In Copernicus, they use carvedilol. In MERIT-HF, they use metoprolol succinate. And in seniors, they had nebivolol. Now, nebivolol is something which we know is a new beta blocker. And where did it stand in seniors? When you look at it, it was found to be superior to placebo in reducing risk of primary composite outcome and all-cause mortality, which also in hospital administration. However, when primary outcomes were examined individual, there was no significant difference between nebivolol and placebo. And that's the reason why it was pushed as a second grades, this thing. So when it comes to mortality reduction, when you looked at it, everything, then there was a mortality reduction, which was clear, but not as much as SIGBIS, Copernicus, or MERIT-HF, where they did find that mortality reduction was very, very, very significant to the tune of about 35% or thereabout. Now, we are not going into the discussion what happens to NYHA class, whether progressive heart failure reduction happens or not, but all beta blockers do reduce sudden cardiac death. And there may be improvement in quality of life, though it was only significant. The p-values were significant only in metoprolol succinate usage, but there was a trend towards improvement of quality of life, though it did not conform to statistical significance. Now, this is what happens with beta blockers. These are 4 trials, US carvedilol program. Like I said, carvedilol is a non-selective beta blocker with alpha-1 activity. Now, this is leading to dilatation of the arteries, yet it is a non-selective beta blockers. So you have to be careful when you come to using an asthmatic patient, avoid carvedilol and instead try to pick up bisoprolol or metoprolol succinate, not tartrate. So this was 65%. When it came to
Mr. Amit?
Yes, sir.
Uh,
Do you
I
lose
I
think.
signal?
think Dr. Samir's internet has stuck.
Yes, sir. Yes, sir.
Sir got disconnected. Ankit, can you call up, sir?
Yes, sir. I am on call.
He can have his connection through his mobile, through hotspot. That might be a bit easier.
Yes, sir, we are trying that.
Yeah.
Sir has joined back.
Yeah, he has joined back. Thank you.
sorry.
No problems.
Sorry about that, but this is exactly what happens when automatic things become autonomous. So trying to attempt to share my slides back. So here I was when I said that let's look at the advantages these beta blockers can do. And this is what it is. If you look at the different beta blockers, the number needed to treat is varies from 15 in Copernicus to Capricorn is 43 with heart failure, and it prevents one death in these many patients. Thus, beta blockers are very effective in patients with heart failure. This is the optimum dosages in which you should target. Unfortunately, most of the times, all of us use very little of these medicines, especially metoprolol succinate, where the recommended dosages are 200 milligrams a day. Nebivolol, if at all you use, it should be 10, though the evidence is not very strong for nebivolol, but carvedilol should be used twice a day, 25 milligrams, and bisoprolol 10 milligrams OD. And how you should up titrate is every 2 weeks. Now, these are the survival rates in chronic heart failure as against several other things which are available. ACE inhibitors, how much does it improve? 16%. MRAs, how much does it improve? 30%. ARBs, 17%. But where are beta blockers? 34%. So if you look at the pure sheer percentage of advantage, you get the advantage in beta blockers only, regardless of other pillars, so to say, of heart failure therapy. Now, CKD is an Achilles heel. Why? Because ACE inhibitors, ARBs, MRAs. These are three subsets where hyperkalemia becomes a rate limiting factor for their usages. So hyperkalemia is induced by beta blockers also, but not as much, because some bit of beta blockade action prevents the RAS activity also, beta blockers. So, but it is not as dramatic as what it is there in ACE inhibitors, ARBs, or ARNI. So medications which can be given is everything except that when it comes to hyperkalemia, then beta blockers are better off than most others. and digoxin is something which is to be prevented. Now, these are the medical therapies for stage C of heart failure with reduced ejection fraction, and magnitude of benefit is demonstrated enormously in RCTs with ACE inhibitors, ARBs 17%, beta blockers 34%, aldosterone antagonists 30%, and hydrolysine nitrates. The only problem is hydrolysine nitrate is that it has been tried and tested only for Black Americans, and nowhere has it ever been reproduced in any other study to prove that hydrolysine nitrates should become as strong therapeutic indication as what it is there for beta blockers, aldosterone antagonists, or ACE inhibitor, ARBs, or ARNI. Now, these are certain empirical antihypertensive strategies in heart failure patients with persisting hypertension. So by and large, we'll consider only heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. So we start with ACE inhibitors, ARBs, or ARNI plus beta blocker and a loop diuretic. This is a presumptive. Loop diuretics do not improve survival even by a day, but for symptomatic relief, they become a strong pillar of usage. Then you can switch to ARBs, either which ways, or you can use ARNI. If there is coronary artery disease evidence, then you add statin. Now, the problem with statins is that heart failure with reduced ejection fraction, there were 2 trials which were done, which said that if you use statins in poor LVs, you probably do more harm. And these was Corona trial, and another was GC heart failure, where they said that if you use statins in reduced ejection fraction, but this is not the scene, because if you have coronary artery disease, statins have to be given. So this debate continues, but till such time we have more data on yes or no answers, we continue to give statins for coronary artery disease. Now, calcium channel blockers for reduced ejection fraction is a relative no, unless you find that the blood pressure monitoring is such that you are not able to handle it by addition of diuretics, beta blockers, or ACE inhibitors or ARBs, then you have to add calcium channel blocker. But otherwise, preferably do not give calcium channel blockers in heart failure with reduced ejection fraction, though they can be used very liberally in patients with heart failure with preserved ejection fraction. These are the advantages of effects of beta blocker based on RCTs. And when it comes to heart failure with reduced ejection fraction, very strongly indicated. Heart failure with mid-range or preserved ejection fraction, the data is not very sufficient for major adverse cardiovascular event, and we need more large RCTs. But in case there is somebody who's got atrial fibrillation, or there is somebody who's got hypertension in mid-range, then they become a reasonable choice to be added. And certainly in atrial fibrillation, you should be not hesitant to use beta blockers. Post-acute coronary syndrome. Now, this is till 3 years or not. This debate will continue, but it reduces mortality and it reduces reinfarction, can increase risk of heart failure and cardiogenic shock though. So be careful when you have to initiate it in an acute coronary syndrome, because if you're attempting to give it, then you should see that he should not be one of those people who are sitting on a borderline heart failure or on a borderline cardiogenic shock. Then you can worsen it. But when you have to give it in long term, this certainly reduce mortality. And this is a data, though from pre-reperfusion era, but it still holds true. When it comes to stable coronary artery disease without recent acute coronary syndrome, then we don't have enough data on major adverse cardiac output, and especially if you have a normal left ventricular failure. But if you have angina, then it becomes a reasonable choice to control angina. Beta blocker are very necessary. Now, this is how you have to up titrate beta blockers every 2 weeks. First of all, whenever you have to initiate beta blockers, calculation of ejection fraction becomes of priority. Less than 40% is something where you have to give beta blockers. Rule out the major contraindication like cardiogenic shock, symptomatic bradycardia, 2nd or 3rd degree heart block. These are the ones which are to be sorted out. And when it comes to up titration, every 2 weeks or so, you can increase it. So metoprolol, start with 12.5 or 25 milligrams daily and target it to 200 milligrams a day. Carvedilol, you can start with 6.25 milligrams. We are more conservative. We start with probably 3.125 milligrams, which in many Western countries, it's not available as a dosaging tablet. But yes, we can be a little more conservative. Bisoprolol, we are a little more liberal. We start with 2.5 milligrams and target to 10 every 2 weeks. And what you have to see is the patient intolerant of increased dosages? Watch for worsening heart failure, bradycardia, hypertension, and fatigue. Achieve maximally tolerated dosages if you are not able to handle it, or if the heart rate, if the blood pressure becomes lower, and you still want to control your heart rate, then it is reasonable to add ivabradine. And in SHIFT trial, they found that there was a good 17% or so reduction of mortality with ivabradine. Now, strategies to increase tolerance are that you have to keep reducing your diuretics, keep reducing your AV nodal blockers, if you are giving, and reduce calcium channel blocker dosages so that your blood pressure permits you to increase more of beta blockers. However, if there is a contraindication to beta blockers, then you have to avoid it till such time these things, the contraindication is over, and then you can reassess regularly and find out the eligibility at some point of time. Something about heart failure with preserved ejection fraction. I wish science knew more about heart failure with preserved ejection fraction, because there is so little that we understand, because it's not a disease of the heart. Heart failure with preserved ejection fraction, in my own understanding, is a comorbid condition to several things. So whether it is lungs, heart, liver, visceral adiposity, kidneys, skeletal muscle, everything gets messed up if you have stiffness of the ventricle. So let's look at a little few of these things in a little more detail. When it comes to lungs, then with secondary pulmonary venous hypertension and preserved ejection fraction, you can have increased pulsatile load on RV and lead to RV dysfunction. And there can be an impaired respiratory muscle metabolism. When it comes to abdominal issues, you can have an abdominal compartment syndrome, because there is a cardiac preload which increases, leads to coronary vasoconstriction. Long-standing congestion leads to splenic third space fluid, non-occlusive blood ischemia, gut flora translocation, and endotoxin-mediated inflammatory response. When it comes to kidney, like I said, that there is a passive venous congestion, which leads to renal impairment, fluid imbalance, oliguria, hypertension, and diuretic resistance. Similarly, we have some involvement with skeletal muscle, which can be leading to impaired peripheral vasodilatation. And when it comes to ventricular vascular stiffening, you limit the systolic reserve. Now, this is by and large the hardware and the software. The hardware is myocardium and collagen, and the software could be having some risk factors like overweight, obesity, hypertension, diabetes, COPD, iron deficiency, anemia. These are all things which hamper and leads to or cause and effect. We don't know. We are still debating what is the cause, what is the effect, but these are associations which we know occur. How do you assess heart failure with preserved ejection fraction? This is something which I love, because this is my bread and butter. I live out of diastolic dysfunction, and in cardiac structures, the LV wall thickness, LA volume, you have to calculate. You have to calculate ejection fraction and global longitudinal strain. You have to calculate the mitral inflow velocities. And not only that, you have to calculate the mitral annular velocities. And the best way to calculate non-invasively or get a fairly good idea about the left ventricular end-diastolic pressure is if you have a ratio of mitral inflow E and the E prime, which is a mitral annular E ratio. And if it is high, then you are pretty much sure you are dealing with some kind of a diastolic dysfunction, which is of significance. Now, whether this translates into RV dysfunction or not, This can be settled by looking at the tricuspid regurgitant velocities, and you can calculate the pulmonary artery hypertension. Like I said, that heart failure with preserved ejection fraction is extremely comorbid. So with advancing age, advancing or long-standing hypertension, atrial fibrillation cause and effect, we don't know, but atrial fibrillation and heart failure with preserved ejection fraction are very closely associated. Howsoever garbage kind of a diagnosis COPD is, still, if you have to label somebody's COPD, then you know that these are the patients who are at an increased risk of finding, not risk of finding, increased association is that you can find heart failure with preserved ejection fraction in COPD. And not only that, anemia is something that if it is less than 10 gram percent, then if you look at this study, the p-values were 0.0001. Now, heart failure with preserved ejection fraction and AF is a challenging symptom overlap because both have got same problem, that symptoms and this thing is overlapping. And obstructive sleep apnea has come into a major discussion these days when it comes to mechanism for atrial fibrillation. So you do whatever for atrial fibrillation. Do drug therapy, do RF ablation, do yoga, do whatever. If you don't correct obstructive sleep apnea, these are the patients who will defy your all these therapies and come back with atrial fibrillation, no matter what. So if you look at the reason for atrial fibrillation or any tachyarrhythmia, you have to have automaticity, a trigger, and a substrate. So if you look at these three things, all these three things are available because of obstructive sleep apnea. Worst is if there is a combination of hypertension and diabetes. Obstructive sleep apnea and obesity, I am not keen to differentiate the two separately, but obese people can be without obstructive sleep apnea and you can have thin OSAs, but that is not by and large the rule. By and large, obesity, stroke, and obstructive sleep apnea go hand in hand. And these are the ones where if there is a re-entry, you can calculate, you have delayed after depolarization and early after depolarization, which can increase the focal activity. This is from phase 4, delayed hyper after depolarization, and early depolarizations are in phase 2 or 3 of cardiac. Now, what to do for rate control and how in case of symptoms or deterioration of heart failure, further reduction of heart rate is needed. So beta blockers, digoxin is something which has lost the battle. It has lost its sheen, but at some point of time in heart failure with atrial fibrillation, there was a small study done in Italy where they said that even in heart failure with preserved ejection fraction, atrial fibrillation, fast ventricular response, if you give digoxin, you actually do more harm, you kill more. But by and large, if you need to do something with beta blockers, digoxin carefully can be added. And the philosophy is very simple, that if you look at B, it beats, the heart beats at 200 beats per minute and it lives so little. Whereas an elephant heart beats 40 beats per minute and the average age is about 60 to 70 years, and few of them, and several of them will cross a century mark. Heart rate as a predictor of all-cause mortality in hypertension is there. Heart rate, if it is greater than 88 versus heart rate lesser than 65 is corresponding to a 6-fold increase in sudden cardiac death. So lower heart rate is better. So these are certain guidelines which have been there, and 2012 guideline says that no treatment has yet been shown convincingly to reduce mortality and morbidity in patients with heart failure with preserved ejection fraction. In 2016, it said no treatment has yet been shown convincingly to reduce mortality and morbidity in patients with heart failure with preserved ejection fraction. Now we are looking at what? We are looking at alternative diagnosis to find whether we can do something for the heart failure, because now instead of targeting only heart failure with preserved ejection fraction, you are targeting other organs. You are targeting COPD, you're targeting obstructive sleep apnea, you're targeting anemia. You are doing several other things other than just target the heart. So do symptomatic treatment with diuretics, treat the hypertension, control heart rate, maintain sinus rhythm as much as you can, treat ischemia. Spironolactone had its own philosophical and theoretical and intuitive advantage. Reason being that MRAs are antifibrotic. So if you had to reduce stiffness of the ventricle, the most efficient drug should be MRA. But TopCat trial was one trial which fell flat on its face. But now the data churning is happening. And with this data churning in TopCat, they're saying that no. When you look at women, it has got an advantage. Or when you look at mid-range heart failure, it has an advantage. But for all practical purposes, this is still under question. The beat goes on the importance of heart rate and chronic heart failure. We know about it, that atrial fibrillation and heart failure frequently occurs. And if you look at the prevalence of atrial fibrillation as the New York Heart Association function class increases, the association increases. So in SALT, it was 4.2%, which was a SALT prevention trial, but consensus had almost half their patients with atrial fibrillation. Not only that, treating heart failure in sinus rhythm can prevent or delay onset of atrial fibrillation. All-cause mortality in heart failure with reduced ejection fraction depends on heart rate. Now, this is from 11 randomized controlled trial. This is, if you look at all-cause mortality, this is a paper which was published in 2017, which said that higher heart rate at baseline was associated with greater all-cause mortality in sinus rhythm. So you have to maintain a low heart rate in sinus rhythm, but not in atrial fibrillation. So now this is a dichotomy, because all this while we thought that atrial fibrillation, we either control the heart rate or we reverse it. But this is a dichotomy which happened, and this was proven in this study. But there are a few more studies which are very latest, last year only, which have contradicted this once again. So we don't know what the truth is, and the jury is still not home about atrial fibrillation and heart failure. So effect of beta blocker on all-cause mortality, etiology, NYHA class, we know that there is, you improve, the relative risk is better once you give beta blockers, whether it is Cibase, whether it is Merit-HF, or whether it is US Carvedilol. But by and large, the beta blocker which really helps is probably with no overlap from the line of unity. No overlap from line of unity is the Carvedilol trial. What about elderly patients? Again, it is overlap is there, but if you look at this, they improve significantly either which ways when you give beta blockers. And this is again repetition of the same, but with a little bit of changes. And here, if you look at the benefit in elderly population, you can see that if people have no beta blockers, their cumulative survival is lesser. And as the higher dosages increase, their survival keeps on becoming better. Now, this is the trial I was trying to talk and highlight, that this is as from cardiology research practice, where they showed that there was a decrease in mortality with beta blocker therapy in heart failure with preserved ejection fraction associated with atrial fibrillation. And they concluded that in heart failure with preserved ejection fraction, patients associated with AF beta blocker treatment is associated with significantly lower all-cause mortality, but it increased the risk of rehospitalization due to heart failure. Which beta blocker? We have talked about it. Now this is preoperative evaluation of hypertensive patient. In preoperative evaluation of hypertensive patient, you should continue beta blockers, and especially if they have got coronary artery disease, arrhythmias, hypertension, and the level is class 1C. So for whom? Post-MI, certainly. How long? Probably 3 years. Hypertension and CAD and angina? Yes. Hypertension and elevated heart rate? Yes. And if you have to combine the two, then should you have any space for beta blockers with ACE inhibitors? Yes, because these are three subsets, and LV dysfunction also where there is some. Now, the problem with fixed dosages that in a failing heart, you want to keep changing the dosages every 2 weeks. Whether it is of ACE inhibitors, ARNI, or beta blockers, everything keeps changing. So single pill combination can be instituted once you have reached that stable level beyond which you don't want or don't wish to change medical therapy. This is what happens in after acute myocardial infarction. You do a judicious use in beta blockers, especially if you have no contraindication and if you don't have high risk of shock.
Sameer, may I request you to a little bit shorten it because we have
So this
another
is
talk.
my last slide.
Okay, thank you.
This is my last slide where there is a benefit for non-cardiac surgery, reduced ejection fraction, reduced myocardial infarction, cardiac surgery. And this is relative risk reduction of one, which is neutral, which is there in hypertension, reduced ejection fraction, and atrial fibrillation. So this is something where there is beta blockers have a space or don't have a space, but at least they don't cause harm. And rest of the things for non-cardiac surgery and stroke prevention, hypertension and mortality and non-cardiac surgery, these are the ones which are harmful. So I'm just going to close my talk here, and sorry for the interruption and sorry for taking a little extra time, but I thought it was worth it. Thank you very much, sir, for a patient listening, and now all yours and Bhupati's.
Thank you, Dr. Sameer. It had been a very, very exhaustive journey over last 5 decades or so. What we have learned about beta blockers, not only on the types of beta blockers, but the indications, different indications, and the way forward, the comorbidities, and the two distinct phenotypes of heart failure, the reduced ejection fraction and the preserved ejection fraction. I have a good opportunity to invite my friend and a colleague and probably younger than both of us, Dr. Nagendra Bhupati. Are you live, Nagendra? Nagendra, are you live?
Yes, sir. Yes, sir.
So I invite you to be the next speaker, and maybe you fill in the gaps which are very important for the clinicians, and you find that there'll be pearls in clinical practice. So I invite you and request you to go through your presentation so that we can have question answers in the end. Thank you. Please start.
Thank you for this opportunity. It's thank you for this opportunity, sir. Am I audible?
Yes, you are.
Okay, thank you for this opportunity, sir. It's a great pleasure to talk in front of my mentor, Dr. Rajiv Agarwal, sir. He trained me a lot. He trained me, most importantly, social medicine. I learned a lot from him. I used to call sir as a man of aldactone. I mean, so aldosterone antagonism. So I learned a lot from sir in managing patients. So it's a great opportunity to present this topic, beta blockers in heart failure, from evidence to clinical practice. My talk has been made simplified after Dr. Sameer Srivastava's talk. Most of the thing, whatever I'm going to discuss has been, may look like a repetition, but it's worth repeating. If it is, if you feel kind of too much of repetitive, you can stop at that point of time. I will accelerate my presentation then and there. So no need to define about heart failure. It's a failure to receive the blood or pump the blood.
Nagendra, I'll request you to touch the salient points so that we have some time for discussion.
Yeah. So we all know about this. We all know about this topic. So the cause of heart failure has already been discussed. So this point we have to remember, heart failure is a big burden for our country. We all know that India is the capital of diabetes. They are the capital of CAD. As CAD is going to be higher and higher, in 2025, it's presumed that more number of patients with heart failure will live in India rather than a smaller state total population in Germany. So the 12-month mortality rate for patients with heart failure is something around, varies from 17% to 7% based on the clinical status. Similarly, the 12-month hospitalization rate varies from 44% to 32%. Most of the heart failure deaths are because of either arrhythmia related, that is VTVF related, or heart failure related progressive heart failure that depends on the clinical status of the patient. And though it is believed that heart failure with reduced ejection fraction is similar like heart failure with preserved ejection fraction, the all-cause mortality is not the same. It's actually worse with heart failure with reduced ejection fraction. Heart failure is, there's no patient who, once the patient with heart failure is diagnosed to have heart failure because of any kind of etiology, he can never be labeled as a stable patient. There's going to be a chronic deterioration in his clinical status, all because of the activation of such neurohormonal system that starting from sympathetic nervous system, renin-angiotensin system, endothelin system, a reduction in BNPs and cytokine storms. There is going to be remodeling of LV because of LV hypertrophy or LV necrosis myocardial after myocardial infarctions. These secondary damage leads to LV remodeling that further aggravates the situation of LV failure. So it's a kind of vicious cycle that sets once after an initial event. So he can never be a normal if he's going to be let down on his own. We all know about the stages of heart failure, how to diagnose heart failure. Our management of heart failure is a multidisciplinary team approach. So any therapy in cardiology, rather than cardiology in medicine, should aim to increase the survival of the patient, should aim to decrease his disease burden by reducing his symptoms, by increasing the quality of life and decreasing the hospitalization. Most importantly, it should increase the survival. It should have some survival benefit. The armamentarium in the management of heart failure has already been discussed. So I'm going to focus only on beta blockers. This is the simple table made by me. This is the trials involved in managing drugs involved in treating patients with heart failure. So let me focus only on beta blockers this time. So let's focus on sympathetic system and heart. We all know heart has beta has got three receptors: beta 1, beta 2, beta 3. As Dr. Sami has told before, 85% of the receptors in heart is beta 1 receptors. Let's presume this is a beta 1 receptor. Once the sympathetic system acts on the beta 1 receptors, it leads to activation of CAM pathway that causes increased heart rate, increased contraction, and better relaxation. It also not only causes increased contraction, it makes the heart to receive the blood for the next time by producing a better lusitropic effect. This is a normal heart. In the normal heart, parasympathetic system predominates as compared to sympathetic system. In abnormal heart, in heart failure, especially in heart failure with reduced ejection fraction, the parasympathetic system signal is reduced while the sympathetic signal is significantly increased. There's going to be a significantly elevated local norepinephrine. As the heart failure stages progresses towards the end stage heart failure, the norepinephrine level may go down. That is because of kind of very end stage heart failures. So what does this sympathetic activity in the systemic level or in the local cardiac level does to the heart? It increases the myocardial hypertrophy, it increases necrosis, it increases arrhythmia that leads to sudden cardiac death. Similarly, the sympathetic system, by acting on the beta 1 receptor that is located in the GJ apparatus, increases renin, and hence it activates RAS, leading to increased sodium absorption, leading to edema. That is the reason for having edema whenever the patient is going to have a significant sympathetic stimulation also. So similarly, in the peripheral vascular system, it causes vasoconstriction and vascular hypertrophy. So Dr. Rajiv Agarwal sir has made my topic very easy by describing about the invention of beta blockers that started from 1960s all the way back to 1988, exactly when Sir James Black was awarded Nobel Prize. So we know the anti-ischemic properties of beta blocker 5 decades before. Currently, we know all the anti-hypertensive, anti-heart failure properties of beta blocker. So how can be a beta blocker can be useful in patients with heart failure who are already having a reduced ejection fraction? Most important thing is it decreases the systemic sympathetic load along with reducing the local sympathetic load, thereby reducing the heart rate, thereby reducing the myocardial oxygen demand, thereby make the heart to receive the relax better so that it can receive more blood. It alters the calcium signal pathway, leading to reduced arrhythmogenic activity in the heart. That leads to reduced VT and sudden cardiac death. Let me focus on the evidence justifying my topic. It starts with the MDC trial, metoprolol in dilated cardiomyopathy. Patients initially, people were scared to give beta blocker. Though the registry data shows beneficial effect of beta blockers, this is the first randomized study that was done way back in 1990s. in patients with dilated cardiomyopathy with EF less than 40%, class 3, class 4 patients. Though there is no benefit of decreased death, benefit of increased survival in this particular study, they found the quality of life increased, hospitalization decreased, and EF decreased along with reduction in wedge pressure. The metoprolol used here is a short-acting form, metoprolol tartrate. Followed by bisoprolol-based CBIS 1 trial, published in Circulation way back in 1994. Again, a randomized study, EF less than 40%, class 3, class 4, 640 patients, 320 in placebo, 321 in bisoprolol arm. There is no survival benefit, but improvement in clinical outcomes, in the sense, in the soft clinical outcomes, that is quality of life. The editorial accompanying this article says that maybe the study is not powered for the hard endpoints. This is the first study on carvedilol, precise, that again showed that there's beneficial effect of carvedilol in patients with heart failure with EF of less than 40%. There's a reduction, improvement in ejection fraction along with improved quality of life with reduced hospitalization. But this study, in addition to the soft endpoints, also showed reduced fatal and non-fatal clinical events. So that led to the first pivotal study in United States, carvedilol, US carvedilol trial, that randomized patients who are having ejection fraction less than 35% in class 2 to class 4. They found that in addition to the reduced hospitalization, it reduced death. This is the first study that powered for clinical event that showed there's a reduction in death in patients with heart failure if they are going to receive carvedilol. The rest is history. This was followed by CBIS 2 trial that randomized 2,600 odd patients to bisoprolol versus placebo. Again, found significant mortality benefit with patients who were receiving bisoprolol. The study was stopped prematurely because the data monitoring committee found that there's a significant benefit. The absolute risk reduction is something around 6% to every 25 patients, less than 20%. There's going to be a increased life. Every one life is saved if you are able to treat 1 by 6, something around 15 to 16 patients. Significant amount of mortality benefit was observed in this particular trial. Then from the experience with the MDC trial, where metoprolol tartrate was used, later on a controlled release formulation of metoprolol, that is metoprolol succinate, was invented, and then that was studied in this largest heart failure trial based on beta blocker. This is the largest heart failure study based on beta blocker at this point of time. 4,000 odd patients were studied, and they also found significant reduction with mortality in patients who are receiving beta blocker. And it was not only confined to all-cause mortality, they showed reduced CV mortality, reduced sudden death, and reduced death from worsening heart failure. Again, in this particular study, patients who are having LV function less than 35% with class 3, class 4 were included. This is the first study in the history of heart failure that included patients who had ejection fraction less than 25%. No other drug has been studied in this particular population. Systematically, these kind of patients have been included in the prior studies. In this particular study, carvedilol was compared with placebo in patients with euvolemic heart failure patients, well compensated, and having an ejection fraction of less than 25%. They found that in spite of having such a low ejection fraction, carvedilol saved life in such patients without any increased adverse events. And this benefit was not showing any difference based on sex, based on age, based on continent, based on LV function less than 20% or more than 20%, based on ischemic or non-ischemic, based on recent hospitalization. So unanimously, it has been concluded after the study that irrespective of the ejection fraction, patients should be started on carvedilol, provided it is clinically, patients are clinically stable. Okay, after this, how about comparing each beta blocker? This is the study. There's no other study that is available comparing beta blockers. Comet, where carvedilol was studied, was compared with metoprolol tartrate. Carvedilol was compared with metoprolol tartrate, and it was found that carvedilol was superior to metoprolol tartrate. It reduces death by around relative risk something around 17%. But the metoprolol tartrate that has been studied in the study was metoprolol that was studied in this particular study was metoprolol tartrate. Metoprolol succinate has never been compared with carvedilol. After this, the chapter of tartrate is done. No one uses the tartrate in patient with heart failure. So this is the summary of whatever we have discussed till now, starting from 1975 till now, starting from the most hazardous drug in patient with heart failure to most effective therapy in patient with heart failure. Now, this is one of the most effective therapies in patient with heart failure. This is a summary of whatever we have discussed. This is one important slide which I would like to show. It is not starting the therapy; it is trying to update the dosage. So we will see how to update later. Start from 6.25 with carvedilol. We can go up to 25. And patients who are obese more than 100 kg, we can go even up to 50 mg twice a day. Similarly, for bisoprolol, starting from 1.25, we can go up to 10 once a day. For metoprolol, we can go from 12.5 once a day to 200 once a day. The Copernicus, carvedilol went up to 25 milligram twice a day. Capricorn, it's a post-MI study. I didn't discuss about the study because of want of time. It's a post-MI LV dysfunction. Again, beneficial effect was shown. The MAC target dosage was 25 milligram twice a day. So in addition to decreasing death, it also increases quality of life, decreases hospitalization. The reduction in death happened by reducing both sudden cardiac death and heart failure related, progressive heart failure related death. So this is the number needed to prevent one death. This is meta-analysis data that shows that the significant amount of life can be saved by giving beta blocker rather than by giving AC inhibitors or ARBs. But this data has to be interpreted with a pinch of salt, since newer drugs are available like ARNI, which shows better the safety profile, better efficacy profile as compared to beta blocker and AC inhibitor. So this is the one which I described, starting from 1.25 going up to 10 for bisoprolol. No need for repetition, I think. So if you see a patient with heart failure, which drug would you like to start, whether AC inhibitor or beta blocker? This is a very important question. In this is the one, the question, because all these beta blockers that have been studied systematically, all these patients were receiving AC inhibitor. There is no study starting from CBIS 2, Copernicus, US carvedilol, Merit HF. All these patients have already been on AC inhibitors. So we don't know which one to start first. But since we know these strong data that AC inhibitor patients who were on AC inhibitors, they're going to be started on beta blocker. They did well with a good amount of safety profile. That is the one that is being followed universally at this point of time. Should we wait till we we reach a full dose of AC inhibitor before starting beta blockers? Absolutely no. In all the previously described studies, not all patients are having full dose of AC inhibitors. They have been receiving little much lower doses of AC inhibitors, and it has been clearly shown that patients who are receiving smaller doses of AC inhibitors along with beta blockers, they did better as compared to patients who were receiving only AC inhibitors even with their maximal dosage. This is a very important point I would like to emphasize. So starting with AC inhibitors, the patients remain stable. Start with low dose of beta blockers rather than uptitrating going to full dose of AC inhibitors. So when to start beta blocker? This study published way back in 2004 showed that if the patient is stable enough after hospitalization, before discharge, we start a beta blocker, then at the end of 1 year, we are able to save 18% of patients. A significant number of lives can be saved if you ensure beta blocker is prescribed before discharge in appropriate patients. So that is the reason why in American Heart Association promotes get with the guidelines. So these are all the important aspect that is being noticed when a patient with heart failure is getting discharged. We can start slow, but definitely we should start. How about uptitrating beta blocker? Unlike AC inhibitors, which can be uptitrated every third or fourth day, beta blockers has to be uptitrated very slowly, once in 2 to 3 weeks. What is the reason? Because the already heart is kind of decompensated, recovering some amount of inotropic, chronotropic, and lusitropic effect because of our beta agonism. If you take out the beta block, knock out the beta agonism by providing beta blockers, then it may harm the patients. It may lead to fluid retention. It may cause significant drop in LV function that lead to hypotension. Hence, it is not recommended to uptitrate the beta blockers before 2 weeks. That is one important reason. Whatever the negative effects that can happen with beta blocker in such a sick patient usually happens within 3 to 5 days. So observe these patients closely during the first 3 to 5 days. If they are stable, then usually they don't deteriorate further. In case they develop hypotension, you can, with the hypotension, you can decrease the dosage of beta blocker. Also, you can decrease the dosage of diuretics that can also cause hypotension if the patient is not in fluid overload. If the patient doesn't develop hypotension, but he has developed fluid retention, you can increase diuretics. You cannot accordingly to different situations. Do they tolerate beta blockers, such as sick patients? Yes, definitely, irrespective of their diabetes, their COPD status, their peripheral vascular diseases. 85% of the patients tolerate beta blockers safely. It's only this 10 to 15% of them who are critically ill, I would like to emphasize, who may not tolerate beta blockers, especially new onset acute heart failure patients. New onset acute heart failure patients because of acute MI in class 4 ambulatory status, go slowly, but definitely you should try. If you are not able to try during the current hospitalization, then definitely you won't be able to try during outpatient visits. Can we withdraw beta blocker in patients whose heart failure symptoms improve after beta blockers? This is the biggest review, systematic review and meta-analysis that has addressed this particular question, that found that it's not only beta blockers, all the heart failure medications that have been given following which LV improved or patient became asymptomatic should not be withdrawn unless that particular cause for heart failure is a reversible one, like tachycardiomyopathy, alcohol cardiomyopathy, or a peripartum cardiomyopathy, or MI and revascularized LV is normal now. If they are not having any reversible cardiomyopathies, please do not interfere with the therapy. They have done their job. Do not interfere. And interfering with such therapies may harm the patient by increasing hospitalization or even affecting their life. Is withdrawal of beta blockers necessary during heart failure hospitalization? This question has already been answered by Dr. Samir sir. For want of time, I would like to skip this question. In acute heart failure patients, if the patient has tolerated beta blocker, you can decrease the dosage by half, or even you can continue the same amount of beta blocker therapy, because abrupt withdrawal of beta blocker causes and leads to a kind of uninterrupted sympathetic activity on the heart that may increase arrhythmia and even that may interfere with the life of the patient. So do not try to stop beta blocker acutely. Go slow if at all you want to stop it. Medications don't work in patients who don't take them. Similarly, medications don't work in patients if their healthcare professionals don't prescribe them properly, don't uptitrate them. There are apps which are available that can be used. This one app from Canadian Healthcare Society, which actually helps to titrate, monitor, initiate specific drugs according to a particular patient need. Remember to identify right patients for beta blocker therapy. Start slowly, but please start. Monitor them carefully. 85% of them tolerate. Uptitrate slowly and try to reach trial tested or study tested dosages. To conclude, beta blocker is one of the pillars in the management of heart failure with a reduced ejection fraction. Evidence-based beta blocker therapy are the drugs that should be tested. That includes bisoprolol, carvedilol, and metoprolol succinate. They increase life in patients with heart failure. They decrease hospitalization and also increases quality of life. They definitely improve every function. Thank you all.
Thank you, Dr. Nagend. We had a wonderful presentation of fact, data, and clinical application in relation to beta blocker and different patient population. It's too much of information for digestion, but at the same time, there are a couple of points which are very, very important. Like Dr. Samir said, that beta blocker, out of all the therapies, they are probably the best in reducing the maximum relative risk reduction. That is one point we should carry home, that beta blocker should not be lost in the hype of newer drugs. The another thing which is upcoming is the role of beta blocker in heart failure with preserved ejection fraction, atrial fibrillation, and they continue to be a good drug in heart failure with preserved ejection fraction. I think two very important points you raised was, I remember a trial called Carmen trial, which talked about whether to start beta blocker or ACE inhibitor first in a patient of heart failure, of course, chronic heart failure. And they said both can be used. But let me say, I never use beta blocker as first line of drug. I always start ACE inhibitor and then build a beta blocker. The another very important thing, I think very, very important point you raised was that if your patient is doing well, don't stop them, because probably the sympathomimetic activity is causing deleterious effect and causing ventricular dilatation. A patient who is lucky enough to reverse to normal should not warrant and make you think that let us stop beta blocker. No, they are the ideal candidate who has proven clinically that they need them most because the ventricle has positively remodeled and got back to its normal shape. So with these words, I'll say another thing which I remember, and there is a very famous trial called Mocha trial with carvedilol. Unlike ACE inhibitors, with Mocha trial, what had been shown, there is a linear relationship in beta block carvedilol dosage vis-a-vis EF improvement and mortality reduction, which has not been shown with ACE inhibitors like Atlas trial. So another thing very, very important to understand is that up titration of beta blocker is very important because there is a linear relationship between positive remodeling and mortality reduction, which is not seen with ACE inhibitor and ARBs. So with a couple of these issues, I'll say we have limited time. Dr. Bhupati, if you want to share a line or two, what else you want to share with our audience, and that will be the wonderful thing.
Yes, sir, I agree with you. There's one study by name CBIS 3. That is the only study as far that is one other study which I remember comparing enalapril first versus bisoprolol first. That study, though it showed that the per protocol analysis was not having any significant difference whether we can start beta blocker or enalapril.
Yes.
In general, because all other evidence-based studies have utilized AC inhibitor before giving beta blockers, I would definitely hesitate giving beta blocker as a first-line therapy before initiating AC inhibitors. And I was trained by you, so those habits have been inculcated by you too.
I don't know whether they are good habits or bad habits, but so Ankit, do you want us to prolong it further, or it's the end of the Zoom because we have lost Samir again? So how
There
you
are a few questions in the chat box.
are there any questions in the chat box?
Yes, sir. Yes, sir.
Yes, sir.
Just go ahead.
So the first question is role of beta blockers in preventing sudden cardiac death in patients with resting heart rate. Yeah, Dr. Samir sir has clearly shown that there is a significant role of beta blocker in patients who are in sinus rhythm, who's got resting heart rate more than 90 in heart failure. There is going to be significant survival benefit in such patients. There's no question about it. And we both have stressed the importance of evidence-based beta blocker therapy. That is only bisoprolol, metoprolol succinate, and carvedilol. These are the three studied agents that has been shown to decrease mortality and improve survival in addition to increase LV function. Even in co-op study, appropriate guideline-directed medical therapy has decreased mitral regurgitation from 3+ status to either 1+ or 2+ state in 1/3 of patients. So guideline-directed medical therapy, they cause reverse remodeling and change the severity of MR in addition to improving LV function. And the other question is, when should beta blocker be given in acutely compensated heart failure? Sir, Dr. Rajiv, so would you like to take this question, sir? When should beta blocker be given?
Dr. Samir is back. All difficult questions should be passed to Dr. Samir.
Well, acute decompensated heart failure, I'll not risk giving beta blockers because these are the patients. So there are two things. One is that already a person is on beta blockers and he has decompensated, or it is new onset of acute decompensated heart failure. So if it's a new onset of decompensated heart failure, I will not risk giving beta blockers. However, If there is already a person who's on beta blockers and then he has decompensated, I will probably reduce some bit of it. I'll make him euvolemic and then start up titrating it again. But no, I will not withdraw it in case he has gone into an acute decompensated heart failure. Dr. Rajiv, your comments on this, please.
No, I agree that if there is de novo patients who is not on beta blocker, none of us will have the guts to start beta blocker, because sympathetic system is a double-edged sword. You need it in a failing heart. At the same time, overdose of sympathetic system is deleterious. And clinically, there is no parameter to decide where is the balance, where is the sweet spot. So it's very, very difficult question and foolish to start beta blocker in acute decompensation. But at the same time, there is a consensus to continue beta blocker if the patient is on beta blocker in acute heart failure. Let me say very honestly, I never do it because I find it very, very difficult. I withdraw most of the time, put these patients on ivabradine and bring back beta blocker once the heart rate is once the condition stabilizes. Although I must say very strongly, this is not the guideline position, but I don't continue. I bring them back on ivabradine, stabilize them, and then display after a couple of days beta blocker again. That is how I do it. What is your comment on this strategy?
So ivabradine at this point of time for acute decompensated heart failure and control of heart rate probably would be an off-label usage, but all of us use it.
Yeah.
And when it comes to need for beta blockers, so you can reduce them some bit, make them euvolemic, and then go ahead. But yes, there used to be a point of time when we used to also withdraw completely beta blockers in acute decompensated heart failure. But
I'll try to do
put them
now
on
in the next
IABP.
couple of months, and this positive input by you, reduce the dose and all those things. And maybe I'll share my perception again, because that is how the meeting is. We learn from each other. I used to withdraw, and I'll take this positive input that we reduce the dose and see how they behave, because sudden withdrawal is not recommended. I agree. I'm conscious of the fact. So let me see what you suggest, how I learn on that point. And another thing, Sameer, these therapies like sacubitril valsartan, aldosterone inhibitor, beta blockers, MRAs, there is lot of emphasis they should be displayed within 1 month. And they say the mortality reduction is perceived within first month. But I find it very, very difficult to find a patient who can tolerate all four together, even in suboptimal guideline directed dosage. What is your take on it?
So I totally agree with you, because these are 4 or 5 drugs. Because now, why are you forgetting SGLT2 inhibitor?
Yes. Yeah.
So you don't know what to start first, and where are you?
Yeah, you don't know, and patients don't have that kind of pressure head, renal functions, potassium status that you can go on with all these 4 drugs. And my general clinical acumen is, if the patient is borderline, kidney functions are fine, I go with aldosterone and SGLT2. When the patient improves, if there is no bronchospasm, heart rate modulation, then more pressure comes up, then ACE inhibitor and ARBs, and subsequently Vimada. That is how I go about it. If the pressure is good, renal functions are good, then you start with Vimada, go the other direction down the line. So there are multiple ways, and now this is a unique opportunity, what we say, a personalized medicine, that how the patient's clinical characteristics are around us, and that will require some kind of clinical judgment to judiciously use these therapies one by one in quick succession.
Correct.
Nagen, you want to say something more?
One thing I would like to add is the acutely decompensated heart failure. If the patient is going to have a poor cardiac output, not only decompensated heart failure in the form of pulmonary edema, if there is poor cardiac output in the form of decreased urine output, cold cami peripheries, at that point of time, I usually stop beta blockers, sir. If the if the cardiac output, clinical cardiac output for a particular individual is preserved, I would like to continue. I will try to continue a beta blocker or reduce the dosage. But if I feel the cardiac output is gone in the form of, even if the pressure may be 780 systolic, but if the urine output is down for those kind of picture, as we all know, sir, at that point of time, I would like to stop. Otherwise, I try to decrease the dosage of beta blocker and see what exactly is going on. Next thing is coming to this SGLT2 inhibitor, these the other newer drugs. I still wonder why Lasix does. I mean, furosemide doesn't decrease mortality, while SGLT2 decreases mortality. The primary mode of action, the heart failure therapy for SGLT2, in addition to all those proposed antifibrotic activities, it is the natriuresis that causes heart failure improvement in symptom. Though people, I mean, often say that diuretics does not decrease mortality, it adds life to years rather than years to life. So I love diuretic, giving diuretics in a patient who is needed actually. It
Yeah,
definitely the
yeah,
amount of symptomatic benefit,
yeah,
acute symptomatic benefits,
yeah.
diuretic is tremendous.
Even
No,
spironolactone is
that is true. That is true. But let me say, uh, there are two trials, two things I want to share right across. One is your question about the reduction in mortality with diuretics. Diuretics reduce intravascular volume and sympathetic activity reflex, while the SGLT2, they reduce intercellular interstitial fluid,
interstitial.
and that is the postulated mechanism that they reduce. They do not reduce intravascular volume. So that is one mechanism. And only last week, I believe there is a trial called Embrace Heart Failure Trial, which has beautifully has shown the fall in PA pressure within 2 to 3 weeks. And all of us know that if PA pressure falls in a cardiomyopathy patient, it has to do wonders. So diuretics, of course, nobody can replace diuretic in terms of acute management, but the moment patient become euvolemic, they find less and less place.
And I mean, why do we forget that even MRAs are diuretics?
Yes, yes. MRAs are diuretics. And MRAs again is a wonderful drug. And the dosage is 25 to 50 milligram. Aldosterone is out of patent. Apleneron is out of patent. So they are wonderful drug. And let me say, there is 31% relative risk reduction with the apleneron in 30 days. That is what I remember. So these drugs work very, very fast. They are not only diuretics in a way, they are neurohumoral modulators. So you should not be talking about these drugs as diuretics. They are more than that, and I feel they are neurohumoral modulators.
And again, if everything was sorted
I
out,
remember calling aldosterone.
then what would the surgeons do without putting left ventricular assist devices and cardiac transplant? So we'll leave some things to them also.
Yes, yes. So Ankit, I
I
think
remember Rajiv call aldosterone antagonism as medical ICDs.
yes, yes. Aldosterone inhibitor is, I strongly feel that they are medical ICDs. There is sudden cardiac death reduction. And if you see, Bhupati, we extend it, and Samir will agree that the indication of ICD in non-ischemic cardiomyopathy is getting more and more diluted.
Diluted.
And because of these drugs, you have Vimada, you have beta blocker, you have apleneron, about oblique aldosterone, and there are papers which have shown that the sudden cardiac death in non-ischemic dilated cardiomyopathy has drastically reduced over a period of time, and you have to demonstrate scars on MRI to justify your usage of ICD. But ischemic cardiomyopathy is altogether different ballgame. So Ankit, we can call it a day. I do not know how much the audience learned, but I'll say I am definitely benefited by two wonderful speakers who talked about the science and the art of medicine. I thank Dr. Sameer Srivastava, Dr. Nagendra Bhupati, and I'm sure the company will provide us another opportunity in times to come to talk on such an important issue as beta blockers. Thank you very much, Dr. Sameer, for
Thank you,
sparing
Dr.
your
Rajiv, and
evening with
it
us.
was an
Thank you,
honor to be
Dr.
with you.
Nagin Bhupati, for sharing your time with us. And Ankit, if you want to say something, please close the meeting with your remarks.
Sir, hello.
Yes, you are audible.
Sir, thank you for your nice presentation, both Dr. Nagendra and Sami. And Mr. Amit Shah.
Uh, at the outset, sir, so you can hear me?
Yes, we can.
Okay, great. Sir, thank you. It's a privilege for us at Lupin to have three stalwarts in the industry where, I mean, we can hear you for the entire day with the kind of knowledge which we get from you, and I'm sure we have a huge number of audience who has been listening to you. So thank you once again, sir. We'll not stretch it further because I think we are just
I'm sorry, I had been naming you as Ankit. You are Amit, so
Sir Amit Shah
apologize.
over here. My full
I
name is Amit.
apologize for that.
So
Amit,
Ankit, you can go offline now. And thank you, sir. Thank you, Nagendra,
I
sir.
should say thank you to Dr.
thank you.
Rajiv.
Thank you,
Had
everyone.
this been
Thank
in
you, Samir.
Meerut,
Thank you, Nagin.
Pardon me, sir.
till midnight. We
Uh,
have had sessions in Meerut which used to continue till midnight.
okay. So we can actually listen to you for hours and hours because
Oh,
for
it's
us
all
also it's a
right.
privilege.
Samir, the moment things open up, you are due to Meerut.
Oh, yeah, I'm due to Meerut in any case.
Yes.
So before we close it off, I mean just one query from for my understanding and as a marketing team also, I'll just two questions that I mean Samir sir has already talked about the sudden cardiac death and all the beta blocker trials had the major one of the major